Singh. I'm a second-year medical student here at UTHSC, and in this project, we looked into the epidemiology, diagnosis, and prognosis of Wernicke's encephalopathy at Regional 1 Hospital, which is a Mid-South teaching hospital located here in Memphis, Tennessee. So to give a little background about Wernicke's, it was initially identified in the late 1800s by a man named Carl Wernicke, who diagnosed people with having 3 common symptoms that's now known as the classic Wernicke's triad. Those include ophthalmoplegia, ataxia, and confusion, as in changes in mentation. From then, we linked it to B1 deficiency, and current practice, at least when I was taught Wernicke's encephalopathy, in my mind, I thought of these 3 symptoms needing to be there. And so current literature so far has identified about a range of 16 to 33% of actual Wernicke's having all 3 of these symptoms. So in this project, we wanted to look at what were possible symptoms that people had with Wernicke's. Additionally, alcoholism is a major link to Wernicke's encephalopathy. However, we were also curious to see, are there other things that could lead to Wernicke's encephalopathy? That hence became our project. So we looked into the Cerner EMR from Regional 1 Hospital for the dates of July 2018 to July 2022, and we were able to identify 37 unique patient files with Wernicke's encephalopathy. So as you can see in the second column in that pie chart there, we were able to analyze a variety of causes linked to Wernicke's encephalopathy. In here, 57% of the patients were linked to alcoholism. A small note to make is that if there were potentially multiple causes, such as pancreatitis, and the patient was diagnosed positively with alcoholism, we filed them in the alcoholism category. So that meant that 43% were not associated with the alcoholism, which was interesting to see. And so in the data collection procedure of this study, we decided to collect things of existing diagnoses, patient risk factors, MRI results, smoking history, substance dependence, what thiamine levels if taken, and their functional outcomes. Additionally, we really focus on symptoms to see what we can look for in patients to prophylactically administer thiamine. So when we were able to look into our causes, the major causes that we found outside of alcoholism fell into categories such as GI disease, malnourishment from stroke and seizure, hyperemesis gravidarum, and others. We even saw a case of Guillain-Barré from diarrheal illness leading to Wernicke's encephalopathy, likely due to malnutrition. So in GI disease in particular, we looked at chronic gastritis, peptic ulcer disease, mild duodenitis, and colon cancer. So these were the main kind of associations we saw between non-alcoholism causes of Wernicke's, as seen in that figure 1. So moving on to results, we also noted that MRIs were obtained only on 54% of the patients. So those 20 patients that had an MRI taken, only 1 result was normal. As a result, those 19 patients had a variety of findings that normally included hyperintensities involving bilateral mammillary bodies, anterior medial thalami, and anterior commissures. Additionally, we were able to see that 86% of the patients had at least 1 positive symptom of Wernicke's encephalopathy, but more interestingly, 0 of the 37 patients had all 3 of the symptoms. So this major finding kind of geared us to see what we can do to administer thiamine prophylactically. And so moving on to substance dependence, a lot of these patients were substance dependent as seen in table 1. And this kind of helped us see why patients abusing multiple substances could possibly have links to Wernicke's. Moving on to results, the outcomes were very interesting to see that 57% of the cases were caught before any long-term impairments were found, meaning there was no memory loss, severe personality changes, psychosis, ataxia, or progression to Wernicke's Korsakoff syndrome, which results in confabulations and more severe anterograde and retrograde amnesia. However, we did want to keep in mind that for those remaining patients who did have some long-term consequences, what can we do to prevent that prophylactically? We also wanted to look at how often the diagnosis of Wernicke's encephalopathy was actually made amongst all these patients. And there was usually a range of 0 to 15 days. The average was 2.5 days and the median was 1 day upon admission into the hospital. We also looked at the dosages administered of thiamine, which kind of varied amongst patients. But in conclusion, the majority of cases that presented to Regional 1 were indeed with alcohol dependence, but 43% were not. This presents kind of a shift from the normalized concept of considering Wernicke's in those only suffering from alcoholism. And so now we can think of how can clinicians be alert of other possible cases of malnutrition that could lead to Wernicke's. I'd like to end by thanking Dr. Andrew Wilner for introducing me to this project, as well as my co-investigators, Caroline Reidy, Stephen Laxton, Donald Gaines. And with that, I welcome any questions.
Did you see anywhere in literature if there are differences in thiamine levels in the alcoholism category versus the non-alcoholism category?
Yeah, so one thing we actually found was that in our patients, at least, thiamine levels are not normally taken in a regular like CBC, CMP. And so we only found a few patients that actually had like a thiamine level drawn, because that would be a special lab request. And there were a wide variety of ranges where it was just like in general decreased. So in literature and in our cases, there was no like average, or I think it depended a lot on the patient, but there was no significant difference between patients diagnosed with alcoholism and those who weren't.
Any other questions? Thank you.
Thank you.